Thank you, Mr. Chairman. I first thank the organizing committee for inviting me to deliver this lecture, especially Professor Ayman Rifai for his consideration. Now we will talk about C3 glomerulopathy, and our agenda will address the key pathological alterations, renal survival, and predictors of C3 glomerulopathy, treatment options, and kidney transplantation issue, and our experience in C3 glomerulopathy. Then we are presenting the C3 supporting communities. As we know that since late 60, the main description for any histological pattern involving messenger proliferation and double contour appearance was designated as membranous polarity glomerulonephritis. And since the late 60s, this morphological description dominated the classification of MBGN. And with advance of electron microscopy and the description of a new deposits, the position of deposits further classified the MBGN into 1 and 2 and 3, while the advances of immunofluorescence give us better insight about the deposits component, as we find that some patients can present with IgG or IgM or any immune antibody associated with C3 and was designated as membranous-proliferative glomerulonephritis type 1, while patients show a composition of deposit formed of C3 alone or predominant C3. And when we talk about predominant, we talk about 2 order of immunofluorescence higher than other immune subject in the pathogenesis. The alteration in the alternative pathway can involve antibody directed against C3, and I mean C3 nephritic factor, or a complementary regulator, mainly factor H and I. In another way, such alteration can occur due to genetic mutations or polymorphism involving the regulators of the alternative complement pathway or this 3 complement itself. All of this leads to formation of higher levels of membrane attack complexes. In the glomerular microenvironment, another activation of C3 occurs, which may be missed unchecked due to showering of the glomerular filtration barrier with a deprivation of C3 leading to further injury. This alteration of the alternative complement pathway actually occurs in other diseases which are interlacing pattern. One of them is acquired partial lipodystrophy. What actually happens is that adipose tissue forms factor D, which are subjected to lysis with C nephritic factor. The same occurs in the retina with drusen formation. Actually, this yellowish pigments in the retina are due to the possession of lipids and protein-rich C3, which is called drusen, which leads to early macular degeneration in age. Furthermore, a more severe form of C3 glomerulonephritis has been described, which is associated with pulmonary hemorrhage, and even plasma exchange as eculizumab therapy failed to salvage these cases, and the patient becomes dialysis dependent. Here is pathology. What actually interesting, especially in genetic mutations, that if you have your genetic mutation near the N terminus of factor H, you are actually having a C3 glomerulopathy, and if you have your mutation near the C terminal of factor H, actually you have a typical HUS, and between them you can get a picture between that and that. And in this case report, they reported a transformation from C3 glomerulopathy into a more aggressive atypical HUS. What you are expected to do for his case? Not much from the primary case, as we do serological markers, we do C3, we do C4, we do kidney biopsy, but genetic testing cannot be recommended at present time for all cases with C3 glomerulonephritis. And actually, what your complement tells, because the alteration is mainly in the alternative pathway, of course you see serum C4 comes to its normal level, while in this disease and C3 glomerulopathy, C3 becomes low, while in the complement factor H rated protein 5, which is now in its way to be designated as a specific disease entity, both C3 and C4 are normal, and even antibodies are lacking. And what about your recent survivor in C3 glomerulopathy? There is no difference between dense deposit disease and C3 glomerulonephritis in terms of renal survival when censored for end-stage renal disease. But actually what happens that 47% of these cohorts developed end-stage renal disease, while half that number in C3 glomerulopathy passed to end-stage renal disease. And your predictors to predict your course of C3 glomerulopathy is serum creatinine at presentation, the presence of crescent or arterial hyalinosis in kidney biopsy, and the age of the patient in patient in multivariate analysis. Even histological indices when applied, like cases of lupus activity index and the chronicity index, was strongly correlated with the course of C3 glomerulonephritis. Even and typically the estimated GFR at time of presentation does off. So what treatment option you have for this poorly understood disease? First, we will look for mycophenolate mofetil. This data from the Spanish group of the study of the glomerular disease examined 60 patients in 47 months. All patients received immunosuppressive treatment show significantly better response than who don't receive the immunosuppressive treatment. And specifically, MMF shows better results than other immunosuppressives. And in terms of clinical remission and doubling of serum creatinine, while it shows statistically insignificant p-value, and actually what happens is that 0 cases with MMF treated has been passed to end-stage renal disease. In the same study, survival for patients censored for end-stage renal disease was better in patients receiving immunosuppressive treatment, and better response occurs with MMF. And we look for soror positivity for C3NF. It didn't differ in response between who is C positive and C3 nephritic factor negative. And what is highlighted in this study is that all patients who has genetic mutation or polymorphism received immunosuppressive. None of them responded to treatment, and all developed end-stage renal disease. In 2017, there is a negative study from Turkey. Actually, they showed there is no difference between patients who received MMF and patients who received conservative treatment, while it emphasized that renal function, younger age, higher proteinuria and lower GFR, and the presence of crescentus and sclerotic glomeruli and severity of interstitial fibrosis and no remission of proteinuria predicts the progression of the disease. Back again in 2018, this case series for Professor Fresenda revealed that MF again gave a response in nearly 2/3 of patients who received MMF and steroid versus other immunosuppressive drugs. Okay. If you look at genetic defects involving factor X mutation, what appears logic that if you replace the deficient, you can get remission. Is it actually happening? In these two studies, plasma exchange for patient who has genetic mutation factor H deficiency successfully reversed the pathology. And the first study was done in twin patients who had dense deposit disease. While these two studies failed to show this response, giving a controversy about plasma exchange. Even in remission after transplantation, eculizumab was the salvage therapy in this situation. Knowing that the key pathological alteration is alternative complement pathway dysregulation, targeting this cascade appears logic, and a variety of biopharmaceutical agent has been developed. The only commercially available agent is eculizumab. One of these complement regulator is soluble CR1 therapy, which failed to show a response. Actually, soluble CR1 therapy actually developed after pediatric cardiac transplantation. It was found that giving it with super physiological doses reaching 500 times its normal physiological condition can inhibit the complement pathway. When we do that in C3 glomerulopathy, it shows initial response and C3 was recovered after 2 weeks, then it returned spontaneously to its pre-treatment level, and even the histology failed to show any response. Combustin analog CB40 can be used, and it gave a promising result. Ocluzumab. Ocluzumab actually it is a C5 inhibitor, monoclonal antibody, which prevents C5 cleavage into C5a and C5b, and eventually the formation of membrane attack complex. In 2011, this case series involving 6 subjects gave us the first data about ocluzumab use, and it showed that it responded in some patients and some patients didn't respond, and showed that elevation of the membrane attack complex before treatment can predict the response. But this study is in the same year, investigating the histological alteration with using of ocluzumab. Immunofluorescence showed no significant reduction in C3 or the membrane attack complex, and electron microscopy revealed persistence of deposits in all cases, and all post-treatment biopsy showed de novo monoclonal staining of IgG kappa type of the same distribution of the C3 membrane attack complex, mimicking monoclonal immunoglobulin deposit disease. And here is the pathology in the pre-treatment and post-treatment immunofluorescence, and there is no reduction in the deposits. When investigating some published cases of C3 glomerulonephritis treated with ocluzumab, there is 11 cases, just 2 of them didn't respond to treatment. What was striking? That the membrane attack complex was elevated or borderline elevated on all cases, except the 2 cases they didn't respond. They are actually normal. That was surprising. In the same cohort, 4 of the 11 published cases showed histological improvement with ocluzumab, and 3 of the 11 actually relapsed after discontinuation of ocluzumab. This trial also proves that ocluzumab proves itself in rapidly progressive crescent glomerulonephritis with severe course. Even in allograft, ocluzumab was the solution for this, and this is the first reported cases for recurrent dense deposit disease managed with ocluzumab. What is problematic about ocluzumab? Once you stop it, again you show decline of your kidney function and the progression of your proteinuria again. The usual regimen for using ocluzumab is 900 weekly for 4 weeks, then 1200 every 2 weeks. And once you stop ocluzumab, actually you show increase on your creatinine and your proteinuria. And what is problematic about ocluzumab? It's its price, nearly $6,400, $500,000. And when you use ocluzumab, it is expected to do the rules. You should use prophylaxis antibiotic for 2 weeks during your ocluzumab use, and don't forget the meningococcal vaccination before use. And regarding the monitoring of your treatment, it is advised that CH5, which is a measure for total complement activity, and the H50, which is the alternative complement hemolytic activity, to be less than 10%. And ocluzumab trough level should be kept between 50 and 100 microgram per milliliters. This specific entity of monoclonal gammopathy and C3 glomerulopathy targeting B cell clones using proteasomib showed response of these patient. Even the pathology showing regression of the immunofluorescent deposits from before and after treatment of proteasomib. With the advance of a novel and functionally active MAPs against the complement factor C3A and C3, and the use specific affinity, immunoaffinity columns allow apheresis of these molecules, and this offers a new techniques for managing your patients. Even the Chinese give them words. Territritium vulverti Actually, it is an extract of thunder gut veins, an old Chinese medicine that can be used to decrease proteinuria for intense liver disease. And soon after each administration, both the British and the Chinese set warning about discontinuing its use due to major side effects involving the GIT, reproductive system, and hematological problems. We all use AC inhibitor and ARPs to decrease proteinuria as any other glomerular disease. But the evaluation of renin inhibitor alaskiren compared to AC inhibitor in C3 glomerulopathy was started last month to be evaluated, and we are expecting in 2024 to receive the result. And what is about the recurrence of C3? C3 glomerulopathy itself is a strong risk factor for recurrence in MPGN cases, and the major risk factor correlated with C3 recurrence is the presence of heavy proteinuria. During the follow-up of patients with dense deposit disease and C3 glomerulopathy, 10 over 12 patients with C3 glomerulopathy in this cohort actually show recurrence, while 6 of 7 dense deposit disease patients showed recurrence with a median recurrence of 14 months to 15 months. Actually, this is the same here. In a trial to consensus about this disease, who has heterogeneous data and a lot of gaps in knowledge, it is recommended that all patients receive blood pressure control less than 120 over 80, receives AC and ARPs for control of your proteinuria, optimal nutrition, and lipid control. Moderate disease patient was described that proteinuria around 500 milligrams or 24 hours, moderate inflammations, or recent increase in serum creatinine. It is recommended to use MMF and steroids. While severe disease where proteinuria more than 2 grams per 24 hours with severe inflammation, marked endocapillary proliferation, and progressive increased serum creatinine, methylprednisolone pulses, and other intracellular immunosuppressive treatments can be used, and the data are insufficient to recommend clozimab as a first-line agent for RBGN. In our School of Medicine, our experienced total registry data was 800. Only we have 3 confirmed cases of C3 glomerulopathy. The first case, diagnosed at 2015, and this stable course, actually low clearance now. Case 2, rapidly progressive, and within 1 year, it becomes dialysis dependent. And case 3 enjoys a normal kidney function over a 1 year till now. Due to rarity of this condition, epidemiologists say it is 1 or 2 patients per million. Communities has been initiated on the internet for supporting patient and their experience with caregivers. Take home message. Currently, there is no serum or histological marker that could predict the nature of the disease progression or response to therapy, but younger age of onset, higher proteinuria, increased crescent sclerotic glomeruli, and severity of interstitial fibrosis may tell. The primary aim for therapy should be prevention of the disease progression as monitored by periodic assessment of renal function and degree of proteinuria. Supportive therapy with ACE inhibitors and ARPs continues to be used based on extrapolation from other proteinuric renal diseases. Steroid and mycophenolate mofetil can be an option for C3 glomerulonephritis. Clozimab can be a potential treatment in rapidly progressive crescentic C3 glomerulonephritis, but available data about its response is heterogeneous, with C3 glomerulonephritis being a disorder of alternate pathway. The use of anticomplement therapy is logic, but question over when to initiate anticomplement therapy and the duration of therapy have yet to be answered. From Ismailia with love, thank you.